Many years ago, doctors sometimes advised women with multiple sclerosis not to get pregnant and not to have babies. We now know that having children and having a pregnancy does not really change the long-term outcome of multiple sclerosis for the vast majority of patients. Dr. Patricia Coyle and Ingrid will discuss her roadmap to motherhood during a time when she had multiple sclerosis.
My name is Dr. Pat Coyle. I'm professor of neurology and vice chair for clinical affairs in the Department of Neurology at Stony Brook University Medical Center in New York. I direct the MS Comprehensive Care Center at Stony Brook. I'm joined by Ingrid, a person with MS, and her young daughter, Jameson. You know, I've said that the prototypic MS patient is a young woman of childbearing age, and therefore pregnancy becomes a major topic. Ingrid, when you were first diagnosed with MS, did you have any concerns about the impact on future children? Did you ask any questions? Did you discuss this formally with your neurologist?
Yes, when I was first diagnosed, it was actually a complete shock. I didn't have any other symptoms except for the optic neuritis. So when I went in for the follow-up and was told that I had MS, I was kind of blindsided. I didn't expect that, but that is one of the first questions that came to my mind was, is it genetic? Can I still have kids? And the neurologist explained that there isn't any proof that it is genetic, that it's likely caused by childhood illnesses or other things like that. So it's unlikely that I would pass it on to my child.
And I think that's very important to emphasize. The vast majority of MS patients have nobody in the family with the disease. There's clearly no gene that passes on MS. The risk is only slightly increased for a child, but not to any great extent. So I think that's a very important thing to emphasize. As you were talking about the timing of pregnancy, and this often comes up, when somebody's newly diagnosed, do they want to get pregnant quickly or do they want to go on treatment and wait to get pregnant? What sort of conversations did you have with your neurologist? What were you told and how did you handle this choice of pregnancy or being on a treatment? And what was recommended to you about MS disease-modifying therapy use in your particular case?
I actually had this conversation with my neurologist on a few occasions. When I was first diagnosed, I had just gotten engaged. And so I wanted to know, do I need to have a baby now or can I wait? What kind of treatment do I need to go on? So what initially we decided was to go on Copaxone, which I was told you can get pregnant on, you would just have to stop after you became pregnant. And so I was on that for a while until I had a relapse. And then I was put on the Rebif, and then I was told that with Rebif or any similar drugs like that, that I would have to wash out of the drug for at least 3 months before trying to conceive. So that played a big part in when I had to switch from the Copaxone. It became more of it had to be planned specifically. I had to be no progression with my MRIs for at least a year, be stable, and then be off the medications for at least 3 months before trying.
That's very interesting because I think this information is changing, it's evolving. We have 15 MS disease-modifying therapies now, and some of the earliest ones, the glatiramer acetate, the Copaxone that you were on, and the interferon betas have been around since the 1990s. We have a lot of pregnancy data. We have well over 1,000 women exposure. And I think increasingly experts are considering that you do not need a washout at all with either glatiramer acetate or the interferon betas. And you could even continue them during pregnancy. A little bit controversial, but there has not been any signal for teratogenicity or a negative effect that's really stood up with either glatiramer acetate or interferon beta. So we are in an evolving area where, although the dogma, the doctrine has been, you don't use a DMT if you're trying to become pregnant, you don't use it during pregnancy, et cetera, we're modifying that. As we get more valid exposures, it seems like glatiramer acetate and interferon beta are quite safe, do not have a negative effect, and you don't need a washout. You could continue them until you got pregnant,
Right.
and then make a decision about whether to continue them or not. Now, let me ask, Ingrid, when you were pregnant, did any issues come up that you needed to discuss with your neurologist? Were there any MS issues that reared up?
Actually, no. The only thing that I had a little bit of right thumb numbness right when I got pregnant, but aside from that, I didn't have any progression or any other new symptoms pop up. So I was
Okay.
pretty lucky.
All right. So that's interesting and kind of what we expect. Pregnancy is an immunotolerant state. We know that MS disease activity goes down in the last trimester, not so much before that, but certainly in the last trimester. So the relapse rate, the clinical attack rate goes down, is low in pregnancy. It can occur, by the way, and sometimes individuals are faced with having an MS attack, and should they go on steroids to speed up the time frame of recovery? And the current consensus is that they can. They can go on safely a short course of steroids during pregnancy, but many MS patients, fortunately, don't have to face that at all. Now, let's move to the postpartum period, which we do have data on it. What were you told about the postpartum period and any particular concerns as an MS patient?
For postpartum, I was told that I believe it was a rule of thirds, that a third of MS patients usually have a relapse after after they deliver, a third are stable, and a third actually feel a little bit better than they had initially.
So that's interesting. One of the things we know is that particularly in the last trimester, MS disease activity goes down. We also have pretty good data in particularly the 3 months after giving birth, disease activity goes up. So that's identified as a postpartum risk period for about a 3-month period. And the data that you were quoted is valid data, but old. In an old series, PRIMS from Europe, from France, about 30% of women with MS had a clinical attack in the 3 months postpartum. In a more recent MS-based global database, only 14% had an MS relapse in the 3 months postpartum. So I think that's something that I do particularly counsel patients about, and we have a discussion about whether we're going to resume their disease-modifying therapy or will they breastfeed or not. And that brings us to our next topic. So what about breastfeeding? What were you told, and what did you wind up doing?
So I wasn't told much about breastfeeding ahead of time, like how it impacted the disease or progression, but I was told that I couldn't go unless I had been on the Copaxone. I wasn't able to stay on the interferons, but I decided to breastfeed. So she was delivered June 22nd, and I stopped breastfeeding January 1st, so I could go back on medication.
So that was about a 6-month period. Did anybody discuss with you exclusive breastfeeding? Did that ring a bell? Or?
No.
No, so it's very interesting. Again, there's new data. There's increasing data available. Breastfeeding obviously is recognized to have benefits, and generally 6 months of breastfeeding is recommended. In general, we say that we don't want to resume a disease-modifying therapy in somebody who is breastfeeding.
Right.
The exceptions are glatiramer acetate, probably just based on the properties of that particular agent and what happens, it's probably negligible. In addition, the interferon betas, the data that we have, the levels in breast milk are also negligible. So probably interferon betas also are compatible with breastfeeding. But what we've come to probably realize, and this is a little bit controversial, but there have been studies that have looked at all the trials on breastfeeding. Exclusive breastfeeding, less than 1 bottle a day, seems to produce the immunological properties that are key to having a beneficial effect. So to summarize, breastfeeding has no negative effects on MS. Many of the studies have found a positive benefit in suppressing MS disease activity, not all. And the common thread seems to be it should be exclusive breastfeeding. That produces the immunological changes that are most likely to benefit MS. So I think it's quite reasonable, although I must say personally, if I have an MS patient where I'm very worried about their disease activity, and it's a choice between resuming an effective DMT or breastfeeding, I'm going to tell them I favor going back on the DMT and not breastfeeding. Ingrid, what do you think are the major misconceptions about pregnancy and MS that people with MS may have?
So I guess the number one thing would be that it is genetic, or that they're going to pass it down to their child, which we previously said. You said that it's not the case. Studies have not shown that there's a high risk of that. But also, I can't tell you the number of times that people asked me if I was a high-risk pregnancy because I had MS. Not the doc, not my neurologist, obviously, but like even the midwives had to double check, and anybody that knows me, that knows I have MS, were like, oh, well, does that make you high risk? And it does not make you high risk in and of itself. I had high blood pressure, so that made me a little high risk, but the MS did not put me in the high risk category.
That's amazing in this day and age that people would not be aware of that. We certainly recognize that the vast majority of MS women who become pregnant have relapsing disease early in their disease, typically not much in the way of disability, and MS does not make it a high-risk pregnancy in any way, shape, or form. It's kind of amazing how much we do know about pregnancy, but maybe we haven't publicized it sufficiently. So it's amazing to me that up until the 1950s, women with MS were told not to get pregnant. It was going to make their MS worse. Completely false. Completely false. The data has really indicated that there's no negative effect of pregnancy whatsoever on MS. In addition, there are some studies that suggest there may be a benefit to pregnancy. And I think we know more and more about pregnancy and MS that we can effectively counsel. We know that disease activity goes down. We know that we can treat a relapse during pregnancy if we need to. We can even do an MRI scan if we need to, although we would avoid using gadolinium-based dye. We counsel on the increased risk after delivery, but exclusive breastfeeding may really help that. And if we need to resume the disease-modifying therapy, we do. And the fact that currently more and more experts are saying we don't need a washout with glutathione acetate or interferon beta, you can continue that right up until the time you become pregnant. I think that's really building on the accumulating data. We have pregnancy databases for virtually all of the disease-modifying therapies, and the more information we can glean, the better, because I think this is a very important hormonal state. Many individuals diagnosed with MS have to face issues about pregnancy.
I think it's important for more people to know that pregnancy is beneficial or doesn't hurt the progression of MS. I think that's important for physicians to know, because I don't think a lot of non-neurological physicians know that, and it's important for individuals with MS to know that they too can have a baby, and it won't hurt their progression of their disease or anything. And whatever risk it could possibly pose, it's definitely been worth it.